along the joint and internally, externally rotate. Some of you may have read that. And as you're feeling for that, you're feeling for the clicking along the joint capsule, right? And then it says using varying degrees or varying varus and valgus stress, etc. If that doesn't elicit the problem, then you go through varying changes. So, in other words, I'm going to internally rotate, right? Internally rotate, and then I'm going to add a valgus stress. And then I'm going to keep internally rotated and keep that same stress, but now I'm adding a varus stress. So he goes back and forth with but whichever way the heel is turned, we're still going to think that's the meniscus. But you may use varying varus and valgus stresses with whichever way the foot is turned. Okay, so the first step with McMurray's is bring the patient's leg up, fully flex it, palpate the joint space, and go back and forth. It has to do with pushing the meniscus all the way back somehow. I'm not sure of the function, but when you fully flex it, it moves it back. Okay, and then by rotating it one way or another, it helps to push it back further on that particular side. Then it's supposed to glide forward when you're doing this. Some sources don't even add varus or valgus stress. They just do it like this. Some sources add valgus stress at different times. So Sousa says, what we're going to do is we're just going to put it here, we're going to rotate it, internally, externally rotate it, and then use varying forces of varus and valgus as we're internally and externally. So I'm going to internally, I'm going to add some varus stress, I'm going to internally add some valgus stress, and so on and so forth. Okay? Does everybody understand what I'm saying?
Two-step process.
Two-step process. Everybody got that? I changed that in the notes. Not here. Okay, so then where we're going to go after that? Lower extremities. Make sure that we have all of our tests done. Alice's test, what are we going to do? We're going to just measure like this, right? Knee heights. Make sure the heels are together, the feet are together. We're going to look for heel heights. Primarily looking for indications of maybe a hip dislocation, maybe some type of tibial length discrepancy. Everybody got that? Eli's. What do we do with Eli's? What's the patient position? So let me have it again. What are we looking for? Hip flexor contracture, right? So we're going to go like this. If this rises up off the table, then primarily we're looking at what? What's contracted? Rectus femoris. Good. What's the next one?
Ober's.
Ober's test. We're going to have the patient lay on their side.
I know I said so as on the test.
Yeah.
Like rectus femoris. So I was just
It can be. It's hip flexor, but I want them to think rectus femoris. We're going to do one primarily for the side. Okay. Okay. But thanks anyway, Doug. Okay. What we're going to do is we're going to bring this over like this, right? We're going to bring this over, and then we're going to ask the patient to slowly lower it to the table. Sometimes people don't want them to lower it all the way down behind the table, behind the other knee. Sometimes people hold on to it like this. I just want you to raise it up like this, extend it, and then slowly move out this way. Hold on to the heel and have the patient slowly lower their leg. They should be able to lower their leg down towards their other leg. If they can't, then it's what? IT band contraction. Okay, next one is? Thomas's test. Have the patient lay supine. And I would like you to do it with their at their knees at the edge of the table. So all the way down the edge. Thank you. And what we're going to do here is we're going to be testing the psoas on this side, right? So we're going to have the patient bring this knee up to their chest. There you go. You can grab it, sort of pull it up. And what we're looking for is we're looking for this to come up off the table, right? And if this does, this again is hip flexor contracture, but now you're getting more into the psoas, right? We should also see this flatten. So if it doesn't flatten, that's another indicator. And how would we know that the rectus femoris was involved with this test? The knee starts to straighten. Very good. All right, what's our next test? Patrick test. So bring the patient back up on the table. Thank you. We're going to get a workout today, Dr. Johnson. Patrick's test, first, what's that?
Is it intersexy shorts?
In our sexy shorts. In our sexy shorts. You should all have these sexy shorts in your office for patients when you're doing various examinations, okay? So what we're going to do is we're going to say to the patient, does this hurt? Right? And they're going to say, if they say yes, you always ask them what? Where, have them pointed out, make sure you know where it is. Okay, then after they say no, then what are we going to do? We're going to do the figure 4 and just let this relax. And ask the patient, does that cause you any discomfort? And they say, yeah, that hurts in the hip, then you stop. Once it starts to cause problems in the hip, then you stop. And that means some type of a hip lesion, right? Maybe some type of AVN or something's going on inside that hip. Okay, that doesn't cause them any problem. Then what we're going to do, I think you should get down to the bottom of the table so you can add a little bit of axial compression in here, stabilize the opposite side, and push this down like this. Ask them if that causes them any pain. If they say yes, again you say where, so on. Okay? What's our next one? Lagares. So Lagares, I want you to just stand up like this, reach down with your superior hand, grab the ankle like this, bring the patient's knee up, bring it over just like this. In fact, you say to them, if at any time this causes you pain, let me know, okay? Because we are doing this in one sweeping motion, okay? So we're going to come up like this, stabilize the opposite side, and I'm going to put some externally rotation pressure down here on this side and ask the patient if that causes any pain. So you're going to pivot to the inferior, docs, when you're doing this, okay? Just like this. Everybody see how you did that? Yeah. Okay. Next.
Scouring test.
Scouring. What we're going to do is we're going to take the patient's leg, we're going to add some compression into the hip, and at varying degrees of hip flexion, we're also going to add some abduction, and varying degrees of internal and external rotation, right? While we're literally taking the femur head and scouring out the patient's hip. So we're putting pressure in, varying levels like this, over this way, and back over here. We're scouring the hip out, and we're looking for what? What are we looking for? What's our concept? What is it? Pain or catching in there, okay? Positive of the lesion, probably, again, we're looking for labral tear primarily. It could be anything going on, right? Arthritis, it could be AVN, it could be a whole bunch of things going on. Next test.
Anvil.
Anvil? Anvil is for what?
Fracture.
Fracture of what?
Calcaneus.
It could be the tibius, it could be the tibial, femur,
Calcaneus.
calcaneus, and you're going to just put a good thump on the patient and ask them if that hurts, right? And then, did I tell you you can do like a stethoscope with the tuning fork on this? Did I tell you how to do that? You listen. Yeah, it's something that I do and someone. Okay, so now what are we going to do after that? You ask them where it hurts, and then the show will show you specifically what. What's the next one?
Trendelenburg.
Trendelenburg's test. We're going to have the patient. If the person has a true Trendelenburg, you'll probably notice that when they walk in the room. Why?
Their gait.
Because they'll have that gait mechanism. Okay? So you want to have the patient somewhere where they can hold on if need be. They can grab onto the table. But you don't really want them to hold onto the table when you're holding that. And you can just have them raise their legs. So let's just say we're going to test these abductors here, right? We're going to test them. So we want them to stand on that one. And there you go. Now this will lower when the glute medius, I think medius and minimus are bad on the right, right? The one they're standing on, that's your hip abductors, right? This side is going to drop down when they raise it. So if you're testing the right, you're standing on the right, and left one comes down. Okay? All right, and behind box number, sorry. What are we doing now?
Craig's.
What's it called? Craig's test. That's for what?
Anti and retroversion.
Antiversion and retroversion. And our angles are what on this?
90.
Susan says what, 12 to 25? 12 to 25 is your normal range. Most sources say 8 to 15. Is that correct?
Mm-hmm.
Okay, so what we're going to do is we're going to bring our patient's leg up just like this, right? We're going to palpate the greater trochanter, and as we do that, we're going to bring it until it is parallel to the floor. Then we're going to measure with a line, a plumb line drops straight down from the ceiling, and we're gonna measure this angle between the plumb line and the tibia, right? Okay, it should be between 15 and 25. If it's greater than 25, that's anteversion, right? If it's less, it's retroversion. Right, less than 15, less than 12, less than 12, greater than 25, okay? The greater number is taking us out towards the anteversion, right? Is that correct? What's next?
Q angle. And
Q angle, you're just gonna measure that. We're probably not gonna do that. Just make sure you know how to do that. And the Q angle, we would expect it to be positive if somebody's complaining of what?